So let's take a closer look at the emergent or resuscitative phase, which begins at the time of the injury and lasts for about 24 to 48 hours. So airway is our first priority. And do you remember the subtle signs of an airway emergency in a burn client? Because you need to know them for NCLEX. We should be assessing for a hoarse voice, think Darth Vader, soot around the nose or in the sputum, and singed nasal hairs. These all indicate an inhalation injury. And we should immediately administer 100% oxygen and anticipate intubation before swelling shuts the airway. Next is circulation and perfusion. So we need 2 large bore IVs in place, and we should administer isotonic fluids. Think lactated ringers or normal saline. And we'll administer the fluids using the Parkland formula, administering the first half of the fluids in the first 8 hours and the rest over the next 16 hours. So how do we know if our fluid resuscitation is effective? We should closely monitor the urine output and ensure that it's over 30 mLs an hour. Remember that number for NCLEX. We should also monitor the client's vital signs to ensure their heart rate is less than 120 and their systolic blood pressure is greater than 90. And we need to focus on extremity perfusion. And we do this by elevating burned extremities and monitoring circumferential burns. These burns can act as a tourniquet, so we should anticipate an eschorotomy or a fasciotomy to relieve pressure and restore perfusion. We must also focus on preventing hypothermia and infection. We do this by applying warming measures such as warm blankets in a warm room. We should also cover any burned areas with clean, dry cloths. And pain management is key. So remember, for analgesics, it's IV administration only. We should avoid PO, IM, and sub-Q injections because burn tissue will affect medication absorption. The only exception to this is the tetanus vaccine.